Thank you very much. Can I introduce Dr. Samer Koussayer, dealing with hostile neck during EVAR, the sealing zone challenges. Dr. Samer.
Good morning, everyone. I'm going to speak about sealing zone challenging during EVAR. We know that fixation is very important in the EVAR and could be a life-saving. To get a good fixation, we need to stick to the IFU. So we need to have a length at least 10 to 15 millimeters, and angulation should be less than 60 degrees. This is a very nice meta-analysis of 7 major study in EVAR by Antonio. He compared hostile versus friendly neck anatomy. And he found that if you have a hostile neck anatomy at the neck, this will increase your type 1 endo leak about 4.5 times and increase your aneurysm-related mortality about 9 times. And another study done by Special, he looked at the influence of multiple hostile neck parameters. And he found that if you stick to the IFU, your intraoperative endo leak would be less than 1%. But if you have 2 hostile neck parameters, this will increase to 6.7%. And if you have more than 2, then this will increase to 16.7%. So what he concluded that if you have more than 1 hostile neck parameter, this substantially will increase your mortality, major adverse event, intraoperative endo leak, and adjuvant procedures. So IFU is very important, but so does the neck quality. Look at the first picture at the top. It looks a very friendly neck anatomy, and we know the EVAR will work very well, even when this patient is out of IFU because the angulation more than 60. When we look at the lower picture, this patient has a hostile neck because he has a reverse taper. But if you look at the IFU, he's within IFU, and we know this patient will have some issue down the road. So the binary IFU system, it's important, but may not be the best method to assess the suitability of the EVAR. The reason why I'm going to speak about short neck. If you have a short neck less than 10 millimeter, what option? Our first option to get a more proximal sealing zone by doing chimney or FEVAR, or you create an endovascular suture line by using Endo Anchors or open repair. But not all short necks the same. We have to differentiate between the neck length and the sealing zone. The neck length is defined by the core lab. It's the length over which the neck diameter remain within the 10% of infrarenal diameter. And look here in the green area. So the first picture is a green one. It has a long neck, where the other two, they have a short neck. But if we just look at the neck diameter, we may call short neck 2 different things. Why is that? Because the sealing zone is different. What the sealing zone? The sealing zone defined as the length over which the correctly per IFU oversized stent is still circumferentially opposed against the aortic wall. So the graft still touching the wall. We're not getting 10-15% oversized, but the stent still touching the wall of the neck. And we can see it here in the yellow area. So in the first one, here you can see patient has an adequate neck because it has a long neck and long sealing zone. Where here, this two has a short neck, but the different, this one here has a long sealing zone. So the graft expected to oppose circumferentially in hostile sealing zone, where here we have a short sealing zone. So the graft will expect to have limit or not even circumferential opposition with the wall of the aorta. Why is that important? Because it's completely different. When you have a patient with a long sealing zone and long neck, then we have an adequate neck, so we get the good seal. If you have a short neck and long sealing zone, we get a seal, but the seal is very weak, so we have to do something else. Where this one, we have a short neck and short sealing zone, we don't have an adequate neck, then we have to get more sealing by doing something else. Give you an example, like this patient, he has a neck which is 20 millimeters length, which is very good, and sealing zone 25. So this patient has an adequate neck, so we just have to do a straight EVAR. Where this patient has a short neck 4 millimeter, but look at the sealing 10 millimeters. So this one, EVAR will give a seal, but seal is very weak, so we need to strengthen our sealing by doing an Endo Anchors. How does the Endo Anchors work? It's create the stability of the surgical anastomosis by providing a transmural fixation of the endograft to the aortic wall. And you can see here, it gives us a very strong longitudinal fixation and give us also radial fixation, which prevent separation of the graft during dilatation of the aortic neck. What about this third patient? This patient has a short neck 3 millimeter, but also sealing zone 5 millimeter. So this one, EVAR will not work. we need to get a new sealing zone. So we need to get 15 millimeter sealing zone. So what option we have? We can go with the Sheever or you can go with the PAVSS. How we decide? Of course, PAVSS is a custom made. It's more consolidated technology, but the disadvantage is need more accurate planning. It takes a time. It's more expensive. Whereas Sheever is off the shelf. It's good for emergency, technically easier. But the problem is the gutter leaks and the graft conflict, especially if you have a narrow aorta. And if you decide to do a Sheever to get a good outcome, you have to stick to 2 rules. First, you need at least 2 millimeter minimum infrarenal aortic neck. And the new sealing zone should be at least 15 to 20 millimeters. So if you use one chimney, the new landing sealing zone should be measured from the proximal AAA to the highest renal. If you do 2 chimney, this will be measured from proximal aspect of AAA to the SMA. Of course, you need to oversize also 30% when you do a Sheever. So in summary, if you have an adequate neck, then EVAR will work perfect. If you have a hostile neck, which that means short neck but long sealing zone, then you can do an ESR, which is an Endo Anchors. If you have a short neck with a short sealing zone, then you need to get more length as I'm doing Sheever or PAVSS. So conclusion, hostile neck is amongst the commonest cause for reintervention after EVAR, but in experienced center, AAA with a hostile neck are manageable with conventional EVAR, but you need to do additional tools like chimney, Endo Anchors, PAVSS, or PAVSS. But you have to understand the sealing zone to pick up your right tools. And if you have more unfavorable anatomy, always watch out. And don't forget that open repair is always an option, especially in young patients. Thank you very much.